Hi everybody, it's Dr. Ghadir. I hope you are well. Thank you for joining us. We are going to have a great discussion today with Jessica Zucker, and I am going to go ahead and see if I can add her to this live. Hello.
Hi.
Hi Jessica, how are you?
Good. It's great to finally connect with you. Thank you so much.
Thank you. I'm going to make this a little louder.
Oh, am I not loud enough?
No,
Wait.
now it's really good. Now it's
Oh,
really
okay.
good. How are you?
I'm okay. Just getting through all of this. Yeah. What about you?
I'm doing okay. Thank you so much. I was really looking forward to speaking. I think this topic is so important for us to discuss. I think it brings a lot of light to people that unfortunately don't have a lot of places to talk and discuss a very important issue about miscarriage and everything that goes about it. Congratulations on the book. I'd love for why don't you go ahead and introduce kind of yourself for the audience who's looking and not knowing everything about. I'd love for you to introduce yourself.
Sure. So you're breaking up a little. You tell me if I am as well. Can you hear
You,
me
yeah, I
well?
hear you really well.
Great. Okay. So as you might know, I'm a psychologist. I specialize in women's reproductive and maternal mental health and have done so for over a decade at this point. And when I came to the field, when I decided to specialize in this, I really had zero sort of personal connection to the topics. I was seeing patients who had lost pregnancies, who were struggling with perinatal and postpartum mood and anxiety disorders. And I have a background in public health, so I really came to the field from a theoretical perspective. And then 16 weeks into my second pregnancy, I had a miscarriage when I was home by myself. It was a very sort of dramatic and traumatic experience in my life and really affected me both personally and, of course, professionally. So as a result, I kind of went to the data and the research and really looked into, and because, in addition to hearing from my patients how they felt in the aftermath of loss, I really wanted to understand what the research said. And so, as it's approximately 1 in 4 pregnancies result in miscarriage. There's new numbers now from March of Dimes that 1 in 100 result in stillbirth, and so on. And then the research shows that a majority of women are blaming themselves in the aftermath of loss, so that there are these feelings of shame and self-blame and guilt that follow. And I I don't know, this kind of just lit a fire in me that's continued ever since my loss. And I've kind of decided to take this on in my writing, in my work. And then, yes, I have a book coming out next March. It's still just surreal to even say that because I'll believe it when I see it. But I'm very excited about it.
That's wonderful. Well, I think that a book like that is going to be incredibly well received and incredibly important topic. So I'm really proud of you for doing that. It's one of those topics that many people don't want to talk about. And I can tell you from personal experience, when we got pregnant the first time, super easy and had a beautiful child. When we got pregnant the second time, and we were so confident everything's going to be perfect, announced it to everyone way before probably we should have, and then had a
Yep.
miscarriage. Wasn't fun at all. And then it took us about maybe a good 2 years to try to catch up, and all of our friends had delivered, their kids were walking, people we were pregnant with, and we were still kind of struggling. But then we led to the path of infertility treatments and beautiful IVF cycle that led to our twins. So I've been through that as well, and yeah, I've been through
Wow.
that as well, and have beautiful twins from IVF. And then even another surprise baby, number 4, which we totally didn't expect, who's changed our lives. But
Wow.
I think that I discussed this with my wife as well, that I think this happened for many different reasons for me to be able to
Mm.
understand, because I used to have patients have miscarriages, and I was like, oh, you're going to be fine. It's okay. Just moving on. And it's difficult. And it affected myself and my wife in such a difficult way that we had never really expected. So the fact that you're talking about it means a lot. And I can tell you, so many people, my patients, feel so lonely during that time because many of them have been struggling with fertility, and then this happens, and that's even, an extra amount of pressure and difficulty on top of them.
Well, I think the fact that you as a professional are open though about the fact that you've gone through this must help your patients feel so much more connected to you and so much more normalized. Because again, the truth is, it is a normal outcome of pregnancy, albeit, desperately sad or
Yes.
tragic, you know, but it is a normal outcome. And I think that's why it's important that we change this silent cultural conversation or lack of it, and that we sort of upend this antiquated sort of stalemate that we're in around
Yeah.
out of order loss because it's happening and it's not going anywhere. And as you know, as an MD, like you're not looking for a cure. There's not a cure for this.
No, it's not. It's the smartest machine in the world, which is the human body, knows how to do some things in incredible ways. And there are things that we have learned that don't have to allow that to happen too. So when it's done for
Right.
the right reasons and it's an abnormal and unhealthy pregnancy, the body's so smart to take over. When it happens and we're not sure why it's happening, discovering why it's happening and correcting it, for me in my field as a reproductive specialist, and being able to give blood thinners for patients that have blood clotting problems, or being able to give steroids to people to decrease their body's ability to reject the pregnancy. All of these things for me are major goals. And we actually started in the last year, we changed the protocol. We used to do these like implantation failure panels before, after you miscarried or you didn't get pregnant. But we decided, why not do that beforehand?
Amen.
So yes,
So
thank
you
you.
are
Amen. So we offer it for every single patient beforehand. So we evaluate the uterus to make sure that everything is looking okay and there's no abnormalities, because we know that polyps and fibroids and scar tissue inside the uterus can cause miscarriage. So everyone gets a uterine evaluation, which we all have done that. We also now do the blood test beforehand.
Well, a lot of my patients would have been grateful to come to you for that because, as you know, so many doctors don't seem to do that until there have been three losses, correct? Until
Yeah,
they're
I never did that. So we were doing the panels a lot of times after the second miscarriage. And then with time, I realized that there were patients that I knew would prefer to do this after one cycle. So
right.
we started to offer them after one cycle. And then as a group, my 5 partners and myself, we all decided, you know what? We're going to offer this blood test to everyone beforehand. It just does not feel right to offer it after someone has gone down a bad path. And once in a while, we get someone that's like, yeah, I'm fine. I know I'm fine. I don't want to do that. And we say, fine. But we
Right.
offer it to every single person. It's simple. It's one blood draw, and we get a lot of precious information.
Yeah, that seems like prevention. I feel like that's the way our healthcare system should go when it comes to this topic, especially.
Yeah,
Yeah.
unfortunately, in the world of fertility, there are
What?
so many things that are so expensive that adding one more panel of blood tests and one more set of testing on top of things is not the ideal. But that's also, I think, led to us having one of the highest success rates in the country, highest implantation rates in the country. So it's one of those things I find it to be incredibly important.
I see some interesting questions coming in. I don't know.
Yeah, one of the ones I saw earlier was that, is this going to be, are we going to be able to record this? Absolutely. We will. I will repost. I will give access to Jessica as well if she'd like to, but definitely will go up, and we'll put it on the Instagram page and YouTube channel. But there's definitely a lot of questions coming up that are finally wonderful.
Fun.
What panel of blood tests? That's a great one.
Yeah.
So we have an implantation failure panel, and we have something that's called a recurrent pregnancy loss panel. So for anyone that's had a miscarriage, we do the recurrent pregnancy loss panel. It's a little bit bigger and a little bit more comprehensive than the implantation failure panel. The sad thing is the American Society of Reproductive Medicine recommends 3 blood tests if you have a miscarriage. We we go with the panel that's more comprehensive than that. It's not the bare minimum. And they're always doing studies to be cost effective and things. I'd rather be overly comprehensive and get more data than probably I need to, but I think it's a better way to practice medicine for me. Where are you located, by the way?
I'm in Beverly Hills. I think we're near each
Yeah, yeah. I'm on
other.
Beverly Hills on Roxbury.
You're on Roxbury. I'm on South Beverly Drive.
Oh wow, I didn't realize that we're so close to each other.
Yeah.
That's wonderful.
Could have done this in person.
I know. Tell us a little bit about what you do, because you really specialize in mental health and the reproductive field, and I'd love to kind of pinpoint exactly kind of the areas of your expertise.
Yeah, so I primarily, well, since my loss and since I've written so much about loss, I tend to get a majority of my newer referrals over the years are loss related. So, fertility struggles, miscarriage, stillbirth, infant loss, SIDS, terminating for medical reasons, abortion, the whole spectrum, and even selective reduction, all of it. But then I also work a lot with women who are pregnant and are struggling with anxiety or depression or have recently given birth and are struggling with, a variety of mood and anxiety disorders. So those are the primary, things that are related to women's reproductive and maternal mental health. And I also struggling with loss. Can you still see me? You're frozen.
Yeah, I can see you. It went for a second.
Okay.
Again?
Yeah, so with couples on occasion, obviously right now during COVID, it's difficult, but, to really sort of process the grief of loss, because oftentimes couples feel very differently about how they experience grief. That, the woman who had this happen within her body tends to feel sometimes very, like you said earlier, lonely, isolated, self-blaming, and sometimes feel like, she feels like her partner is nowhere to be found emotionally because of just what a different sort of experience it is for him or her. Obviously, a partner can be a woman as well. So
that's great. That's wonderful. There's some questions that are popping up that I think are really great to answer. And I got to tell you something, I think there's nothing more stressful than your first pregnancy ending in a miscarriage. It's very different than if you have a child or two at home and then it happens. So because the thoughts start going through your head, will I ever have a child? Am I going to not be able to get pregnant again? But I do have to say, as a reproductive specialist, one of the things that we get concerned about when someone has a miscarriage is that because of poor quality, and sometimes that poor quality goes along with a major decline in egg number. So rather than waiting and waiting for it to happen again, I think it's much smarter to be proactive, and get some simple assessments done. Simple things that, there's a simple blood test called AMH, and the AMH blood test is a simple blood test that can be done on any day of the month. We can arrange the day after, or even the day of your consult afterwards, to come in and do a simple blood test and go home. We're doing most of our consults by phone, so it makes this whole process much easier for people who don't want to move around. But that one blood test gives us a really good understanding of where someone stands. And it's important to know that if you had a miscarriage, is it related to a major reduction also in your egg reserve? Or is it related to something else? And again, it happens. It's one of those things that happens because the body is very smart and knows how to take care of the body really well. But I think it's really reassuring to know after a miscarriage that, oh, it wasn't my egg reserve. I still have a lot of eggs. And usually when people have a lot of eggs, they're usually of decent quality, versus when they go down to very low levels, usually quality goes down with it. So I would say that is a really important blood test to assess after a miscarriage, just for some reassurance. And if it is very low, to become maybe more proactive in your desires to move forward with some treatments. One of the major reasons that we did IVF after that is not only we were having difficulty getting pregnant again, but after that entire process, I did not want to ever deal with a miscarriage again.
right.
And the only thing that is available to do to increase your chances of not having a miscarriage because of all these abnormalities and things is to do genetic testing on embryos and make sure that they are 100% healthy. Now, we come from a practice where we're considered one of the largest fertility centers on the West Coast of the US with one of the highest success rates. But I'd have to say that probably like 99% of our patients do genetic testing on their embryos. And we have a lot of people that come to us and say, yeah, my other doctor said I only had 1 or 2 embryos. I shouldn't do the testing, never got pregnant, or I got pregnant and I had a miscarriage. And that's exactly why I think that that answer is wrong. And
Yeah.
even if you have 1 or 2 embryos, it's actually more important possibly to do genetic testing to make sure that it's completely healthy before doing an embryo transfer and putting it back into your body.
Couldn't agree more with you. I mean, I didn't end up, getting into a place of having to do IVF, but friends of mine after my loss heavily suggested it because they had gone through it and they were just worried for me that I would go through it again. I, had the opportunity to learn within, I think, 10 days of my miscarriage that my situation was a chromosomal abnormality, which honestly kind of gave me peace of mind, because I had a healthy son and got pregnant so easily the first time around and got pregnant easily the second time around. It was very surprising to have a second trimester loss, of course. But then my doctor suggested I wait 3 cycles, and on the 4th cycle I got pregnant, and I do have a healthy daughter from that.
Oh, that's beautiful. That's beautiful. I did see a comment right now from Rainbow Mama that says, I had 2 PGS normal embryos result in 2 miscarriages. So that is a perfect patient that needs to do the complete workup of the autoimmune blood test and the blood clotting testing and all of the antibodies that can be checked for. Because if you are doing a genetically normal embryo, first of all, it's important to know things about at what stage the embryo was tested. But that is a really good comment, and I appreciate that you put it up there, because just because you do a genetically tested normal embryo does not mean you're covering all of your bases that you should be covering before putting the embryo back. And knowing about the other aspects of your body and your life is also really, really important.
What are those things exactly, though? So
some of the auto antibodies, like lupus antibodies, and to an extent thyroid antibodies, a lot of these things can potentially, even if you put a perfectly good normal embryo back inside of you, they can reject the pregnancy. Also, if the uterus has some issues, just with anatomy, fibroids, things that are not supposed to be there, after a short amount of growth of a normal embryo can cause them to not grow anymore.
Okay.
And so Rainbow Mama is letting us know she ended up using Lovenox, which is a blood thinner, and a low dose of prednisone, which is a steroid, and it resulted in my 1-year-old daughter. And that's the very, very, very smart thing that you did. Those were things, and I have had situations where every test that we did came back normal. And what I explained to a patient is that the risk of going on a blood thinner is really low. The risk of going on a low dose prednisone, which is a really low dose steroid, is really low. And just because we were able to check you for 10 blood clotting factors, for example, doesn't mean that there's hundreds out there that we have not discovered yet or we're not aware of yet. And it doesn't mean that just because we checked you for the 5 autoimmune antibodies doesn't mean that there's multiple that are not tested that were there. So sometimes we just do empiric treatments, and many, many times it has actually helped.
Someone just put up a question about the thyroid. Would you talk about that? Because I do have patients who have asked me about that. And of course, because I'm not a medical doctor, I don't try to speak to it. But
absolutely. So thyroid is really, really important. Thyroid is an incredibly important blood test, a hormone of the body, an organ of the body that needs to be in tip-top shape. The American Society of Reproductive Medicine said that just being in the normal range of thyroid isn't ideal for pregnancy. So for the TSH, the thyroid stimulating hormone, we actually like it to be between 2 to 2.5 while trying to get pregnant. If it's a little lower, I'm perfectly fine with it. But once it starts to go up a little bit, even though the normal range is up to 4.5, and on some labs even up to 5.5, it's telling us that your thyroid is a little bit on the sluggish side. And for good fertility, it's probably smarter to have the thyroid on a more active level. And for that reason, just like we give prenatal vitamins, we sometimes put people on a very low dose of thyroid medicine, which is called levothyroxine or Synthroid, which help thyroid be a little bit more active and a little bit healthier and better for pregnancy.
So you can lose a pregnancy, though, if you don't account for the thyroid? being?
If the thyroid is really out of normal range, yes, you can. I don't think that if your thyroid is like a 3.5, you're going to miscarry. There's millions of people getting pregnant in the world that aren't going into fertility centers and aren't going on a medication when their level is 3.5. But when people are coming to us, that's usually for a reason, and by then they've been through a lot. So we really try to pinpoint and really optimize every single aspect of fertility.
And someone just asked a question about progesterone, and I guess she said that someone told her it was outdated. What is that?
So let me see if I can find that question.
I thought that was
My
interesting.
doctor told me that progesterone is outdated and never recommend anymore. Is that true? That's a really good comment. So I'm a firm. So a lot of doctors gave their patients progesterone, saying that if you don't take the progesterone, you're going to lose a pregnancy. I'm a firm believer. Progesterone is the hormone that comes from the capsule that releases the egg. So every month we have a lead follicle that grows, and once it releases the egg and the egg comes out, the capsule becomes what's called the corpus luteum, and it produces the progesterone. And a healthy pregnancy begins to make the progesterone in a healthy manner to maintain implantation. Giving someone progesterone, if it's not a healthy pregnancy and those levels are low, in most circumstances is not going to make the pregnancy healthy and maintain the pregnancy. You're just going to, on a blood test, take a progesterone level up. So I don't like to falsely give progesterone to people to maintain a pregnancy. Sometimes it even delays a miscarriage, but eventually there's no way to get around it. Those pregnancies are usually because of unhealthy embryo or something else is going on that is not allowing for the normal progesterone level to grow. So that is one thing that I kind of agree that I think it is outdated to just give someone progesterone. I had a patient of mine go back to her OB and said, you know, the OB told her, your progesterone is so low, you're about to have a miscarriage. And we know exactly where a natural progesterone level should be for a IVF cycle, for an IUI cycle, for a natural conception. And it varies. And I think for person to person, that can be very different. And I think the amount of emphasis that was put on giving progesterone to people because they had low progesterones is really kind of an idea that's not being used so much in obstetrics and in infertility. So we're getting some great questions. How do you work with patients with endometriosis and endometrioma? So for patients that don't know what endometriosis is, it's when the lining of the uterus, which is called the endometrium, grows outside of the uterus, either on the fallopian tubes, on the ovaries. When it's a collection inside the ovary and it makes a cyst, it's called an endometrioma. But generally speaking, the endometriosis is the growing of the lining of the uterus and the pelvic cavity. When you get your period, these patients generally experience a significant amount of pain because instead of the lining of the uterus getting fluffy and then you shed it with a period, this is growing and getting engorged with blood like the lining does, but on your intestines, on your pelvis, and on all these other places that have nerve endings in them, but should normally not be getting engorged and having this kind of tissue grow on it. The downside is that endometriosis can cause significant scarring inside of your body. So it affects your fallopian tubes, it can affect ovulation, it can affect egg quality. So for all of these reasons, it can affect an increase in fertility. Once you do get pregnant, though, there's really no correlation other than the fact that sometimes the eggs from endometriosis patients are of slightly poorer quality. There's no clear correlation with miscarriage. And for the patient that's saying she had 3 miscarriages in 11 months, you definitely at this point need to be seeing a fertility specialist.
Is this
true? Sorry, go ahead.
I see something about menopause, and I don't know if it's
I was looking at the same one.
Oh, okay.
It's true that if you do IVF, you have menopause 10 years earlier. Absolutely false. So every month when we release that one egg and you're ovulating, during that process, about 1,000 to 2,000 eggs are released in the process and dying off. Okay, they're not being released to get pregnant, but they're just in the process of releasing that one egg. They're just lost and die off. Doing IVF allows us to capture some of those and recruit some of those eggs, and those are the eggs that come into the lab where we try to make someone pregnant. it in no way does it deplete your eggs and cause early menopause at all. It doesn't take out all your eggs, which some patients have asked me. It allows you to continue to try. If you want to get pregnant on your own naturally, you're absolutely welcome to. But that's absolutely not true, and it does not touch your menopause age.
Very important. There's a chromosomal question here that
let's see.
So in my, I was instructed to bring the baby to my doctor's office, and then they sent the fetus off for testing. But I think this is an important question for people who have first trimester miscarriages. How will they know if it's chromosomally related or not?
They won't, unless they notice that there's no heartbeat, and then your OBGYN does a D&C. And I would caution everyone that it should be a very gentle suction. I no longer really use the curette to scratch and scrape the lining of the uterus. I only do a very gentle D&C, only using the suction, so the lining doesn't get affected. That's the only way. If you get that tissue, you can send it off. Otherwise, there's no way to know if the genetic tissue, or if you bleed and you're able to collect it and bring it into your doctor's office for them to send it in, which I think is a very traumatizing experience. So if you've had an ultrasound and your doctor gives you the option of doing a gentle suction versus waiting and letting it go naturally at home, there are definitely benefits from doing it with your doctor and collecting the tissue and sending it off for genetic testing.
Well, can you say what you said at the beginning of that, just about the D&C, about it being
yes. So
yeah.
A dilation and a curettage is basically when you dilate the cervical canal with an instrument, and then you go in and you suction out the tissues, and then there's a very sharp curette. It's like a hook that scratches and pulls tissue from all the angles of the lining of the uterus to clean it out really well. It can, for some people, cause significant scar tissue afterwards. And unfortunately, that scar tissue can cause damage, and you can sometimes, I've had patients that never got pregnant after that, ever, and had to use a surrogate because their lining was damaged. So when someone has a miscarriage in my office, and I'm doing the D&C, I only put the straw process, which is suctions and suctions. I'm very patient. I go really slow. I put it back in again, and I go again and again with the suctioning. And then I do an ultrasound again. And when I see the lining of the uterus is now really thin and there's nothing left there, I know that I don't have to scratch or scrape the lining of the uterus with a sharp instrument that could affect it.
Yeah, I can see how that would be. It's a scary thing to hear, in a way, that you're saying that sometimes you've seen people not go on to get pregnant again. I think there's like a lot of discourse within the abortion world, pro-choice, anti-choice, about whether or not that having a D&C can affect the future of your fertility.
Yeah, it can. It really can. And I remember when I was being trained 20-something years ago in my OBGYN residency, I remember a couple of doctors saying, you need to scratch it until you can hear a gritty sound. And right now, as a fertility specialist, I can tell you that that's one of the worst things in the world you could do to a patient. There was a question, and there was a comment in there that progesterone was given with IVF, and that is absolutely true. Completely different than a natural pregnancy that is on the edge and potentially may be a loss. When putting an embryo back that the body does not know where it came from and did not release from an egg recently, there's nothing making progesterone. So you have to give the progesterone. We give it in two forms. One is intramuscular progesterone and oil. It's an injection. And the other one are vaginal suppositories as well. We give them both because if you don't give progesterone, the body will not be able to maintain the pregnancy in any way. Let me try to see some of these questions. What testing are needed to find out if your miscarriage was from chromosome? And it's called the karyotyping. The karyotype is the chromosome. I do want to let people know that if they've had more than 2 miscarriages, so to be honest, 2 or 3, then I think it's very important to do the karyotyping on the man and the woman as well, the husband and wife, because that could be another cause that we see that people have these issues with actual chromosome problems themselves, and that's why they're not able to conceive, and genetic testing on embryos is a very important thing. Another question I see here is that my fiance was laid off due to COVID, so the fertility clinic refused to see me alone. I'm not sure if that's normal at all. I came back as a carrier of cystic fibrosis. I was told genetics need to pull. Okay, so when someone does genetic testing on their own body, there's 2 different ways. One is your karyotype, which is your chromosome, and that's genetic test. There's another thing called the genetic screening, which does not check for the chromosomes. It checks for actual disorders that you may carry in your blood. Cystic fibrosis is the most common. About 1 out of 19 Caucasians carry cystic fibrosis. You have to make sure that your partner does not carry that, or else you can have a unfortunate chance of your child actually having the disease if your partner is a carrier as well. Most insurances, excuse me, do cover. Most insurances actually do cover genetic genetic screening. So you should talk to your OBGYN, but I don't see that it's normal that they stop treating him in any way because he wasn't working.
Maybe you can say a thing or two about, a baby being born with cystic fibrosis and how.
So, excuse me. Cystic fibrosis is a pulmonary disorder that produces excessive mucus buildup and makes it incredibly difficult to breathe. Many of the people that are born with cystic fibrosis don't live to be past their teens or past 20. That's why it's an incredibly important disorder to make sure that you and your partner don't both carry. If you do both carry that, there's something called single gene mutation testing, where when we put the husband and wife's embryos and create them all, we do individual tests on every single embryo to find out which one actually has the disease, to make sure we never do a transfer back into your body, versus which ones are just carriers like you and your husband and normal, and which ones even have no more carrier of the disorder.
What is LIT treatments? What does this say?
Comments have come in so fast. Let me see. In which cases do you recommend someone to get LIT treatments? I'm not sure what LIT is.
No.
If you could let us know what LIT is, I'd love to know what that is. Maybe it's an acronym that I'm not familiar with. I'm sorry. The chromosome testing on, there's the ones that are done on products of conception has to go to a lab. The ones that are done on you to make sure you carry a normal 46XX or 46XY chromosome is a blood test. That's the karyotyping test. Great questions. And I appreciate people in the middle of their very busy days on a Friday to watch and send in these questions. If no one has any more questions, I'm more than happy. I want to give someone some feedback. If anyone would, luteal phase defect. Okay. If there's, lymphocyte immunization therapy. So that is a very, very controversial topic. So it's not one that I think is necessarily going to be helpful for most people. But again, it's very controversial and not everyone believes in it. So I think it's really, really important to understand, the need for doing these kind of treatments. There's a lot of things out there as well, okay, that potentially, I don't know, they're out there and there's a lot of myths about them and we don't know if they really help or they don't help. How does an ovarian cyst affect IVF? It depends. If it's an ovarian cyst, there's many different kinds of ovarian cysts. Some of them produce hormones and they can throw the cycle off and it's hard to start IVF. Some of them they have different kinds of things in them that are irrelevant and you can just leave them alone. I think that you should always be very wary about removing a cyst on the ovary if it's not doing anything and it's not questionable and it's not cancer. I think the best thing to do is to just leave it alone. When you take an ovarian cyst out, a lot of eggs will go with it. So it has been shown again and again in studies that when you remove an ovarian cyst, a lot of eggs go with it and your AMH level falls. So be very careful.
I've never heard that before. That's interesting.
So I do want to let everyone know that every about 2 weeks to 3 weeks, my clinic, Southern California Reproductive Center, and our website is scrcivf.com, has a free patient seminar. Now it's a webinar, so you can watch it. We have people watching it from around the world. It is very, very helpful. When people do watch it, there's a code that's given at the end of it that allows them to get a consultation for a much lower price than it normally is. So we know these are people that are dedicated and they want to know and they want to help themselves. So if any, you can register yourself right on the website and they're available for anyone that needs to. We're happy to help and have anyone watch and learn that wants to. And we are very happy that now it's a webinar forum, so people don't have to drive in at the end of the day like we used to do here at this auditorium we had in our building. And if anyone wanted to make an appointment to see you, Jessica, do you want to let everyone know how?
Oh, they can reach out to me through Instagram at I Had a Miscarriage. They can call me at 310-551-3003, or they can look me up on my website, Dr.JessicaZucker.com.
Wonderful. Well, thanks everyone for watching. Jessica, thank you so much. It's been a pleasure speaking with you.
You too.
I can just tell that I can tell you do a great job because you have such a calming effect of how you speak that it's like relaxed me. I was like running around like a crazy person, and now I feel like I went through like a meditation.
Oh,
because there's this a great energy that's being exuded by speaking with you, and I really appreciate that.
That's really wonderful. Thank you so much. Yeah.
No problem. Thank you. And we'll make sure to put this, I'll put this up shortly, and we'll make sure that it makes it so everyone can see it who missed it. Thank you.
Thank you.
Bye-bye.
Bye.